All right, good afternoon, everybody. My name is Eduardo Mireles-Cabodevila. I will be guiding this discussion today on reading the patient ventilator interactions. And this is a survey that was sent out through social media throughout the world for people to working a lot on trying to standardize and to organize how we speak to each other so that we describe exactly what we're seeing. So the first basic rule that I want to put out is what we call that the patient is the reference signal. And when we're talking about the interaction between the patient and the ventilator, today as we go over all the cases, I want you to, when you hear us say late or early, it talks about in reference to the patient. Now, when we are at the bedside, the signals that we have are usually the airway signals. So we either use the pressure or the flow waveforms to imagine what the muscle is doing for the patient, what is happening with the muscle. However, now there's technology in which you can actually have an esophageal balloon and actually see the pressure deformations that happen inside the thorax, and from there know what the muscle is doing. We now also have the ability to put in a esophageal catheter that has electrodes that measure the electrical activity of the diaphragm. And as you can imagine, when we breathe, the signal starts in the brain, then it activates the muscles, and then they generate changes in pressure and flow on the airway. And so normally, so what I'm trying to point out here is that the patient will always be the reference signal for whatever we're measuring or saying in terms of the discordances. And the reference may be what we see in the airway, or if we have the catheter, what we see on the esophagus, or what we see on the electrical activity of the diaphragm. The second item that we need to be aligned with is when we say spontaneous breath, we're talking about the patient controls the trigger, so the start of the breath, the mechanical breath, and the cycle, so it shuts off or turns off the breath. So in a spontaneous breath, the patient controls both the trigger and the cycle. In a mandatory breath, the machine controls either the trigger, so the start of the breath, or the cycle. Now, this is a source of confusion throughout the literature, because some people think that the patient is breathing spontaneously because it's triggering the breath. However, if the ventilator is cycling it, then this is called a mandatory breath. And this is key for us to be aligned when we're describing the breaths that we're going to see. The other term that you're going to hear me talk about is the term discordance. In the literature, usually we use the term synchrony, asynchrony, and dysynchrony to describe the patient-ventilator interactions. However, if you go through what etymologically each one of those words mean, we really are describing very specific interactions that occur with the patient and the ventilator. So a more general term that we use to talk about this is discordance, which means lack of agreement or consistency between the patient and ventilator. Now, one of the simple ways that we have come to understand this a little bit better is to recognize that the patient-ventilator discordance can occur in two types, or two areas, basically. One is in terms of timing, and timing refers to synchrony, meaning the timing of the start of the breath, the trigger, and the timing of the cycle, or the end of the breath. You could also put it in reference to other things, but in general, these are enough for us to talk about synchrony between the patient and the ventilator. So the timing, synchrony refers to time. And the other part that we describe on patient-ventilator interactions is the effort, meaning the amount of support or pressure that the ventilator delivers compared to the amount of effort that the patient generates. So it's the relationship between the pressure from the ventilator against the relationship of the pressure of the muscle. This is important because we have used the term flow starvation, for example, or flow desynchrony to describe this relationship between the ventilator and the pressure from the ventilator and the pressure of the muscle. Here you will see that we use the term work shifting, and we'll talk a little bit more about that. We have described a method, and you'll see a little bit as we go through the waveforms today to try to make them clear for everybody, that we usually will describe what is controlling and what type of mode we're using. We will see several cases in which we have to use the time constant and the characteristics of the waveforms to determine if the load is elastic or resistive. And then we're going to describe in order the patient ventilator interaction, starting by trigger, inspiration, cycle, expiration, and then we look at some volume and patterns. All of this has been described in this paper in respiratory care, which you can use the QR code to find this, and it goes more in detail. For the sake of this survey, we cannot go and describe everything in detail. So what we're going to do today is we're going to present the question that was placed on the survey. We're going to review the waveform, and then we'll use some examples to clarify some of the concepts as you're reading them. I do have to highlight, if you have not realized it already, how important Rob Chadbourne has been in describing and organizing all these concepts for all of us. And without him being my mentor, this would not have happened. So I know Rob is listening, and I appreciate everything that he has done. So let's go to the patient ventilator discordance survey and see the results and the explanations for each one of them. And before I go there, I also want to thank all of you, first of all, for being up here at 7 p.m. And I know that in different parts of the world is also late or very early. And also want to thank you for collaborating with us in helping us understand a little bit more about what we understand about patient ventilator discordance. So this is the first waveform that appeared on the survey. And what you see on this waveform is you're going to see, and there's several like this one. On the top, you see the airway pressure. Then you see so this is airway pressure. Let me change the color of this to yellow. This is the airway pressure. This is the flow. And down here is the volume. And this is from a commercially available ventilator. We know that this is pressure control, so rapidly we recognize that this is pressure control, and every single breath seems to be the same size. So I'm going to say that this is CMB, and I'm going to stay there for a second, just so all the breaths are mandatory. And the question that they ask is, what condition does this patient have? And actually, from just looking at the waveforms, we can rapidly ascertain what it is. So we see lung fibrosis, pneumonia, pleural fibrosis, and emphysema. The answer to this question is emphysema or emphysema. And the reason for that is the presence of a prolonged time constant. Now, there's many other conditions that can cause this. This is just to highlight that the pattern that we're watching here is of obstructive lung disease. The reason why we know this is because there is the presence of a prolonged time constant, meaning the time from when the deflation of the lung started all the way to the start of the next breath is taking a long period of time for the flow to return to baseline. Now, this is governed by what we call the time constant. And for any respiratory therapist or ICU or practitioner that cares for patients on ventilator, we need to understand the time constant. And this is the description of the amount of time that it takes for the volume, the lung pressure, or the flow to change 63% if you're inflating, 63% for each one of the time constants. A good thing to be aware of is how do you calculate the time constant? And it's very simple. It's essentially you multiply resistance times compliance. You have to adjust for the liters there, but it will give you the time in seconds for each one of these periods of time that you have here. So if you multiply resistance times compliance and it gives you 0.5 seconds, each one of these time constants that you see on the screen, each one of these periods here will be 0.5 seconds. The important thing to know is that if you have an increased resistance, which is a bad thing to have, an increased resistance, then the time constant, just if you imagine multiplying this, is going to become longer, which means that it's going to take longer to get to baseline. And on the opposite, if you see the compliance getting smaller, then the time constant is going to become shorter and you'll get there shorter. So for the conditions that have lung fibrosis in which the compliance is low, the time constant is going to be low. For pneumonia, where the lung parenchyma compliance is going to go down, time constant goes down. And in pleural effusion, it also happens the same. But in emphysema, when there's increased resistance, the time constant is prolonged. That's why this is the answer for this question. It took a long period of time for the ventilator for the flow to reach baseline. Here in this waveform, you see what we're describing for you is you will see that the time, instead of reaching baseline as fast as it should, this line that you see here, dotted line in green, is the time the flow gets to baseline. And you see in this model, in which is increased resistance, it's not reaching baseline in the time that we said. So simply by standing in front of the ventilator without doing any maneuver, if you don't see it returning to baseline with this exponential decay, so meaning it's passive, this means that the resistance is increased. All right. The second one is, again, the same waveform with airway pressure on the top, flow, and volume. And in this mode, based on what we're seeing, what we're controlling seems to be the flow. And we know that because it has a geometric shape, so it looks like a square. And whenever the flow looks like a square or a triangle going down in a very geometric shape, this is suggestive of that the patient is on volume control. The other reason is that you see all these oscillations on the expiratory flow, but you don't see them during inspiration, which makes you suspect that this patient, that this is volume control. And then the waveform is also characteristic for that. However, you see a lot of these disturbances during the expiratory flow, and the question says, well, why are these? What are all these abnormalities on the expiratory flow? One is this a sensor malfunction? Is this cardiac oscillations? Is this circuit condensation? Or is this because you set the scale so high that you can see all the aberrancies on the waveform? So by looking at this, the first one let's start by what we know it's not. So the increased gain is highly unlikely because actually this is a perfectly set gain, because you can see the waveform, the inspiratory and expiratory waveform, and it fits within the scale. So you can see everything that you needed to see, and the same with the pressure and the volume. So I would say D is not the case. The other one that it's not is cardiac oscillations, and cardiac oscillations do look like aberrancies in the expiratory flow, and actually in the inspiratory, because we're controlling volume or flow, we would see them on the pressure waveform. But what we see is that they're usually very irregular, and they will match the heart rate of the patient. And here you see that they are highly irregular, and they have not a very clear pattern. So there's this one, then a little bit higher. So this makes this less likely. A sensor malfunction is atypical to think about it. I don't know what type of sensor. It probably would be the flow sensor, but I would say that before this would be a sensor issue. When I have these very nice images over here, this would be most likely circuit condensation, meaning that there's fluid within the circuit that is causing oscillations, high frequency oscillations that you see here. It's important. This is a good time for us to describe. This is the expiratory waveform, and just remember that everything that moves a wave, this is a passive. The one in black is passive, and everything that moves up or away from the baseline, away from the baseline, means that there is an increasing flow, meaning the patient is exhaling more. And if it moves towards the baseline, that means that the patient is inhaling or moving or inspiratory-expiratory flow. So what we see here is just that those oscillations that are happening, that are moving the air back and forth rapidly because of the condensations on the circuit. This is the third question, and this is a very common one that we'll see, and it's a source of pain for many. Again, you have the airway pressure, the flow, and the volume with very good scales. The gain is perfect, so we can see all the aberrancies that we need to do. And this is a key thing when you have somebody on the mechanical ventilation. Your gain has to be appropriately set on the screen. The options are inspiratory pressure rise set too fast, which is the first one, inspiratory pressure too high, the presence of work shifting, or the inspiratory time is too long. So let's start with A. The inspiratory pressure rise is too fast, and I would actually say that that's not the case. The inspiratory rise talks about the moment that the breath starts, and how fast does it take to get to the top of the breath. And when we said that, it's the rise time. The faster you set it, the faster you get to it. So in this case, it was set to a lower than 0 or lower than 100%. It depends what ventilator you use, and it's going to take longer time. So this immediately tells you that this is not the cause. And actually, that would not explain what the red arrow is pointing out, which is what we want you to say. The second one is the inspiratory pressure is too high. Too high. And we do not see that in this case because, I mean, again, there's no features that would highlight that. It could be, but I would say that this would not explain what the arrow is showing right now. So that is not the case that explains the red arrow. Work shifting in what you would see in the presence of work shifting because this is pressure control, you would see the flow, the inspiratory flow, actually moving upwards like this. So it would lose this concavity, which means that it's passive, which actually you can see some of that, how it loses some of the concavity right here. So instead of looking as beautiful and an exponential decay that you see on this one, you see on this one. So a little bit. And actually, you see that the peak flow is not as sharp as on the prior breath. So there's some work shifting, but it's no flow starvation. It's not severe flow. When it's flow starvation, you would expect the pressure to drop below the baseline, which you don't see. And so the last option is that the inspiratory time is too long. And it could be because you see that little peak at the end. This is what you would expect. But I would highlight that this can also be relaxation of the muscles or simply an artifact from the ventilator. But I want you to recognize, if you're talking about cycle, that peak that happens at the end of the breath usually will come when it's a late cycle, will come with the presence of these little pause that you see on the flow. So the zero flow, and then the passive exhalation would occur, which you don't, I mean, you could potentially, you would say that you see it here. And so because of that, I would say, but it looks like a really passive breath. This one less passive, and perhaps some. So of all these options, the only one that could be, and that you have to recognize, is that the inspiratory time may be long. Now, do you need to change that for this patient? Perhaps not. I mean, it's minimal. It could be just an artifact, and so, but that would be the pattern that you need to recognize, and then look at the flow and look for that little pause or shelf that would confirm that this is a late cycle. Yes, it can also be. So we have a word from somebody wrote that there could be activation of the expiratory muscles, and absolutely that could also be happening. That the patient is starting to exhale early, and that's why the inspiratory time is too long. So it would, and you do see the absence of that nice decay. So this also tells you that there's pmos present in this breath. So thank you for highlighting that. The next one is this graph, and this one requires a little bit of eye. So the question is, what happened between A and B? And again, this is a pressure control mode, and we know that because the flow, the inspiratory flow is exponential decay, and we see the pressure being controlled throughout the inspiratory phase. And what you can see, the differences between the curves before we go to the answers, is that you will see that instead of the pressure decaying fast as it should, so it should drop down to PEEP immediately, instead of that, it has this delay in reaching baseline, which actually, if you compare it to the prior one, the other one, it reached baseline rapidly. The other thing that changed is that the expiratory flow, the peak is blunted. So there's less of a peak on the expiratory flow, and perhaps there's presence of activation of the expiratory muscles because we do not see the exponential decay that we would see. So this, and during inspiration, the two waveforms, the two flow waveforms, which is the ones that we would be interested on, look the same. So if the suction catheter had been left inside the tube, I would expect changes both in inspiration and in expiration. Because I don't see that, this is not the case. And similar, it would be if they're biting the ET tube. Unless the patient bit the tube exactly at this point, it's still, the pressure should drop immediately on the airway and you would not see this decay. So biting the ET tube is out. If you were stepping on the inspiratory limb of the ventilator, you technically during expiration should not see abnormalities on your expiratory phase. You should see them through the inspiratory phase, besides the 10,000 alarms. So this goes out. And so what you have left is stepping on the expiratory limb. So something is increasing the resistance to the in the circuit. And so the pressure cannot drop as it should because there's an obstruction before the ventilator valve that helps regulate the pressure. This is similar than what you would see when the expiratory filter, just before getting to the ventilator, gets wet or gets obstructed or saturated. So the answer is B. Again, this is just to demonstrate in these cases how the pressure would normally drop rapidly from the ventilator. And even if the resistance was increased, the ventilator would still drop the pressure rapidly to baseline. The changes that you see when you're controlling the pressure during expiration is in the flow, not in the pressure waveform. So any of these in which there was an increase of resistance should not affect your pressure waveform. They should affect if you're controlling the expiratory flow. All right. This one is also a very common one. This is a waveform that demonstrates, and the abnormality that we're looking for is this little spike at the beginning of the pressure curve. This is again a pressure control breath, and we know that because the flow again is pretty irregular, so we're not controlling the flow even though they're identical. This is a passive patient. These abnormalities are because of what's happening up here. And so we're controlling the pressure. So the spike we see is at the beginning of the breath. And so the questions that we have, the first one, it says inspiratory time is too long. So that immediately goes out because what we're looking at, the abnormalities at the beginning of the breath, not at the end. And at the end of the breath, we still see some flow being generated and it ends. So the inspiratory time actually is shorter than it should be. So this one is essentially out. The inspiratory pressure set is too low. And this peak on the waveform, this talks actually about work shifting, not necessarily about this pressure over here. So this is what I'm going to show you in a second. The next one is absolutely wrong because it says the inspiratory flow is set too low. And because we're controlling pressure, the flow is going to be dependent on the pressure and the resistance and the compliance of the lung. not on the, you cannot set the flow when you're controlling the pressure. So this one is out from the beginning. So here the question is, the pressure rise is too fast. And so that means that we set the rise time as low as we could. And then you see this aberrancy here, this peak. So let's talk a little bit about that, because this is a source of, I think, a lot of the interactions with the ventilator. I'm going to go back in time for a second and just think about the equation of motion. And if you think about the equation of motion, you're going to have elastance down here times volume and resistance times flow. These two added up will give you the pressure from the ventilator if the patient is passive, and if not, it would be the pmos plus the p-vent. But what this does is, the cool part of this is that if you think about the elastance times volume and resistance times flow, each one of them are pressures. So if you add these two pressures, it would be the amount of pressure that the ventilator needs to deliver to overcome the elastance and deliver that volume and that flow. The important part here, so these are the loads, what we call the loads. So what we did here for you to understand that a little bit better is, if you see volume, you see the area under the curve that I'm highlighting here in blue. Volume times elastance will give you what we call the elastic load. And flow times resistance will give you the resistive load. Now, if you agree with that, at the beginning of the breath, just at the moment that when we pressurize the system, what the ventilator is seeing is a high peak flow, and the flow is going and hitting immediately the resistance. The lung has no volume in it, or minimal amount of new volume. So the initial pressure on the ventilator, this little bit, the instantaneous first moment when you pressurize the system, is all resistive load. It's all resistive load. So this spike that we see here, this little spike that can be huge, like over here, is a manifestation essentially of how fast was the flow. So you can see a very high flow hitting against the resistance. Then the endotracheal tube is the first thing that it will find. And so this peak that we see is a manifestation of that resistance times the flow that we're seeing here. And as such, it's just an aberrancy. It's not touching the alveoli. It's not causing alveolar manifestations, because it's just the first pressurization of the system. And actually, if you notice, what the ventilator does is, when it's not, because it's controlling pressure, it sees a peak on the pressure, and then you will see the flow rapidly decrease as the pressure goes down. The ventilator will then adjust to maintain that, and you will see these oscillations. And actually, I'll show you in the next image. So the same that happens here, we could amplify this image, and you're going to see oscillations throughout, because the ventilator is trying to control the pressure throughout the breath. So for those that are obsessed in getting rid of this little peak at the beginning of the breath, it's inconsequential from the standpoint of injuring the alveoli. It's pure resistive load. All right. The next one is this very nice, and the question again asks, what happened when between A and B? What happened? This is the patient before, and what happened afterwards? And here the key for this image is actually understanding the manifestation of the loads on volume control. And this is a square waveform, so you can see that we're controlling the flow. Sorry, I pressed the wrong button. That we're controlling the flow, so it's a square waveform. And there's actually an inspiratory pause. At the end of the breath, there's an endatory pause. So there's no flow. So let's just look at the components of the breath. So we talked about the resistive and elastic load, and when it's a square waveform, the resistance is continuous. It will be the same load throughout the breath. And obviously, if you do a pause, as you see here, the resistive load disappears. And that leaves you with the elastic load, which you see manifested here as this blue triangle. And so if the resistance is high, what you will see is this delta, this difference between the peak and the plateau to increase, or the initial step up, which is the same, you don't need to do the pause, will be higher. However, if it's a compliance issue, what you will see is that the slope of the curve will change, and the end, if you do a pause, the plateau pressure will be higher. So let's take a look at the waveform again. It's volume control, so the flow is controlled. There is a pause, and you can see that there's the initial step up, which gives you this delta between the plateau and the peak. And just by eye, you can see that that actually remained essentially the same. And the plateau went up. So that means that because the plateau went up, the elastance had to increase, which means that the compliance decreased. So the compliance is lower on this patient. And so we know, and then I always like to look at the expiratory phase too. And if you see the expiratory phase, it returns to baseline really fast. I mean, in matters of less than a second. So this is not consistent with biting the tube would increase the resistance, which is not the case. Bronchospasm would increase the resistance. COPD exacerbation would increase the resistance. So the only one that you have left is an increase in abdominal pressure, which would decrease your compliance of the chest wall and the diaphragm, and as a result, the lungs. So really nice example of that. The next one is again another before and after. So what happened from A to B? And we just reviewed, well, actually I painted this by error, but it's the same. This is a flow control, it's a square waveform. And again, there's a pause. And so you see the peak pressure and then the plateau. With the difference between these two is a manifestation of resistance. However, here what you see is the flow is controlled, and you can see the next one. But in the next one, actually everything dropped, and you see this deformation up here that instead of being that nice straight curve that straight slope, now the slope has a negative deformation there and a drop in it, and actually the plateau is also kind of scooped instead of being straight as we had seen in the other one. And so this is a manifestation of what we call work shifting. And for that, I'm gonna just show you an image that will help you understand this. So this is the relationship of the pressure from the ventilator and if there's presence of muscle pressure, so if the patient effort. And in this graph, you have on the x-axis, you have a patient that is passive, so 0 pmos, all the way to the most effort that a human can do. And on the y-axis, you have 0 pressure, so a patient that is not on no pressure or no mechanical ventilation, and the maximum support that a ventilator can deliver. And you can see here a relationship in which, as the pressure on the pressure from the patient, the effort starts increasing, the ventilator delivers less and less support. And the classic relationship for this is what we call is present on volume control, meaning you're controlling the flow. So as the patient generates more pmos, the ventilator will require less pressure to deliver the same volume. The same happens on the adaptive targeting schemes, which are PRVC volume support that do that. So what you see here is that you see a drop in the pressure from one to the other. And so this would make you suspect that this patient has an increase at the presence of something that is decreasing the compliance. And so if you just look at this, there cannot be air leak, and we're going to see several examples of air leak, because the volume that was delivered and that was returned reached zero, so it went all the way to the top and it returned to zero. So there's not the characteristic feature of air leak. If the compliance had increased, then this waveform should have gone up rather than down. Sorry, actually I'm lying here. If the compliance had increased, this waveform would have gone down, as we see here, but we would not see that scooping that we're seeing on the waveform. If the resistance had decreased, then we would see less between this step up, but we would not see that scooping that we're seeing during the inspiratory phase. And so the one that's left is that this is suggestive, in this case, of the presence of patient inspiratory effort during inspiration. Alrighty, and this is useful for me when I'm thinking about these waveforms. So if I'm controlling volume control, like in this case that we were talking about, I'm gonna see the deformations on the pressure waveform. So if I'm controlling volume, the flow, then I will see the aberrancy on the volume. And actually, you can see that there is very clear evidence of effort from the patient. The flow doesn't change, and the volume doesn't change. However, on pressure control, if the patient does effort, ventilators are not very good at controlling pressure. They're very good at controlling flow, but not very good at controlling pressure. And so you will see some deformations on the pressure waveform, but your eyes should be looking at the flow waveform. So when you're on pressure control, I always look at the flow, and you can see that deformation that I talked about. Instead of that exponential decay, you see this deformation on the flow waveform. And then if you're on, there's other modes, we're not gonna go into it, in which they can change from volume control to pressure control, and that's what you see here on pressure control. So the point, this is all work shifting. It manifests differently on each one of them. Some of them are you need to do something, some of them you don't. So technically, and this is a common thing, is in this patient that has work shifting, the patient, even though you see this drop in pressure, the patient is still getting pressure from the ventilator. So there's the ventilator still doing work on the patient. Okay. This one is a spontaneous, a couple of two spontaneous breaths. We also know that because the change on the flow waveform changed. Every ventilator has different ways of telling you that the signal that they are reading is the patient. And actually, for some ventilators, the same ventilator, it may change from software to software presentation. So just be aware of that. But here, the key for that is this is a pressure controlled breath. So you see the pressure being controlled throughout the breath. But you see one breath that is this size and the other one is longer than the other one. You see evidence that this was triggered by the patient, because you see that drop in the inspiratory flow, in the inspiratory pressure before the breath, the same on this one. However, on the same breath, so the question is what happened between A and B? In A, you see the presence of inspiratory effort. There's a little bit of the exponential decay. Then afterwards, the patient exhales. And the flow goes up and then returns to baseline. So it returns to zero. So it goes all the way to whatever number this is, and then it goes to zero. On the next breath, again, we see the presence of the patient trigger the breath, the flow goes up, it peaks, and then it kind of just plateaus and it never returns to baseline. And then there's another kind of the flow increases again, which means that the patient is taking a breath again, and then suddenly it cycles off, and even though the flow had not reached zero. And if we look at the flow kept going up, and then the patient exhaled, and now the flow is at zero, meaning that the patient has exhaled completely, but the volume did not return to baseline. So there's a difference between the inhaled and the exhaled. And so this is classic for the presence of an air leak, and the air leak is actually present during inspiration and during exhalation. So what's happening here is that the patient the breath the air is leaking and it's not reaching the cycle threshold that you would set according to the peak expiratory flow. So it didn't reach that threshold, which you could see it's right here. That would be the threshold that was set. And it didn't reach that. So this is consistent, and this is a classical finding for an air leak being present. And I just put this image here for you to remember. This is what we call the square root sign. And so for those that tremble when on listening to math, it's this feature in which the volume doesn't return to zero, and then the ventilator always resets back to zero and to start the next breath. If not, it would be continue to climb and whatnot. So this is a good feature of the ventilators, but it will manifest that there's a discrepancy between the inhaled and the exhaled volume. Now, this doesn't mean on its own that there's a leak. This can be because the next breath started earlier. It may be there's other etiologies for this, but this, if you see this consistently, one of the differentials is the presence of a leak. All right. Now we move on to another one. This is from a different. So why did it take so? Thank you. There's a question of why did it take so long for it to cycle, and the point here is because of the presence of the leak, the ventilator did not reach the cycle threshold, and so it would continue to deliver pressure. However, now most ventilators have a safety feature for these kind of situations, especially when you're in non-invasive, in which you set a maximum inspiratory time. And that maximum inspiratory time means that if you reach the threshold for time, it will shut off the breath so that you can get out of that, so that you don't continue to inflate the patient forever. All righty. So this waveform is from another different ventilator, but I want you to, it's again on the top is pressure, in the middle is the flow, and on the bottom is the volume. And here the question is, what pattern or what are we seeing here? And this ventilator, when the patient triggers a breath, they put this marker here, this little triangle in pink, that you can see that tells you that the ventilator is sensing that this is a variable that was triggered by the patient. And then you look at the flow, and this is, again, a pressure controlled breath. You can see the pressure is being controlled throughout the breath. You see some aberrancies on the pressure because the ventilators don't control as good as they should the pressure. And then you see the flow, and the flow during inspiration, it goes up, then the patient exhales. And when the patient exhales, you see that it reaches baseline, and then the patient exhales again. It's more clear on the second breath. Again, the patient takes a breath in, triggers the breath, then exhales, shuts the breath off, and then the patient, you can see how the flow is going out, the approaches baseline, tries to cross it, it doesn't cross it, and again exhales or relaxes, and then another breath starts. So the ventilator is triggering, but there is these moments over here in which the patient is not reaching the threshold to trigger the breath. So there is evidence of PMOS, but there's no P-vent. And when you have PMOS and you don't have P-vent, that means that there is a failed trigger, meaning that the patient tried to trigger and it could not trigger the ventilator. You can see how a passive waveform, this one, finally the patient was exhausted, I guess, couldn't do it. And then you can see this is a passive exhalation. That's how it would look. So each time that it approaches the baseline, that's an attempt to inhale. If it moves away from it, it's an attempt to exhale. This is not early triggering because well, we're going to see some examples for it, but every breath, the mechanical breaths that we see here are all being triggered by the patient. And so that means that if it's triggered by the patient, it cannot be an early trigger. That's one of the basic rules. We don't see any double triggering. Double triggering means that there's two breaths with a minimal exhalation in between them. And this actually, we call them multiple triggering because you can have several of them, and there's many causes for them, as we will see. And then it's not false trigger, because in false trigger, what you have is the ventilator thinks that there's that a non-PMOS signal, so meaning a non-patient signal, but the ventilator is reading it as PMOS, is triggering the ventilator. And we don't see that here. We see clear evidence of PMOS there. And so I explained this actively for you guys to see how the waveform moves up and down depending if it's exhaling or inhaling. This is another waveform in which we're going to talk about loads. And so in this waveform, what we see is again a volume control breath. So, and we know that it's volume because the flow is square. And there's an end inspiratory pulse again to help you. This is from A to B. So it changes, it's what happened from here to here. And immediately what you will see is that the initial step up on pressure increased massively. And then just to confirm it, you see that now there's from peak to plateau, instead of being this amount, it is now this amount. So to confirm it, then I go and look at the expiratory waveform, and although these expiratory waveforms have some aberrancies, it's much longer than the other one. And so we know just by looking at the waveform that the resistive load is high, which we know that that's not the case on pneumothorax. We know that that is the case on bronchospasm. We know that's not the case in pulmonary edema, and we know that's not the case in pleural effusions. So this is a classic case of bronchospasm as one of the many causes of increased resistance. It could also be biting the tube, or they left the suction catheter in there, or whatever. This is again just to demonstrate those in the square waveform, and that the increase on the step up at the beginning and at the end, which is all from resistive load. All right, this is from another ventilator, and I'm gonna just walk you through it because many of you may not have seen this before. What you have here, this is again a pressure control breath, and on the top waveform you have the pressure. The second one is the flow. The third one is your volume, and the last one on the bottom is the electrical activity of the diaphragm. So this patient has a catheter placed in the esophagus that is measuring the activity of the electrical activity of the diaphragm. So this is useful in this mode, which is NAVA. The software will show the EDI, the electrical activity of the diaphragm, on top of the pressure waveform, showing you the estimated pressure that it would deliver if you had the mode active. What this is useful for us is that now we have a representation of the patient, the electrical activity of the patient, right here on top of the pressure waveform. So what I want to show to you is, well, let's talk about the trigger. So remember we said that the reference signal is the patient. So the patient breath started right here, right where I'm putting the arrow, which corresponds to around this point. Okay, that's where the diaphragm started to activate with electricity. And what actually we see, if we didn't even have this electrical activity, you can see that the flow at that point is actually, it crossed the baseline, or it's at the baseline, it's just superimposed on the baseline. And you can see that it took a while. This changing color over here means that finally the ventilator recognized that the patient was trying to trigger. And so there is a delay on the amount of time that it took from the activity of the diaphragm to start to the breath to be delivered. And so because the patient is the reference, the trigger started late. And so this would be a late trigger. There's many causes for it. Usually on all the books, what you would see is that you would see a drop on pressure that is pretty long, and that would signal you that there is evidence of activity of that's the classic late trigger that you would see. However, now with this new technology that we have at our hands, we may see what we call electromechanical dissociation, meaning that you have evidence of electrical activity, but barely any evidence of activity on the muscle. And that could be a manifestation, as in this case, that you can see that the resistance is very prolonged, of severe COPD, in which there's electromechanical dissociation as one of the many other causes that there is. But this is a good example for you to recognize what late trigger is. So remember, the patient triggered first, the ventilator triggered later, and it's so late that it's clinically significant, at least on this waveform. It's almost a second later. Yes, if you don't have, so thank you Yusuf, for asking that. So usually here I put a nice example. So I put all the types of trigger issues. And so in the second one right here, you see what you would normally see. You would see the drop in the inspiratory pressure, that it takes a fair amount of time. And this is where there's still ambiguities. I don't possess all the answers, nor I ever aspire to have them, on where the what's the length of time for a late trigger. At this point, what we know is that ventilators should trigger within 100 milliseconds of receiving the signal. And so if you see something longer than that, that may be an issue. But the key here is to recognize it and then try to minimize it by adjusting your trigger threshold, ensure that that's good, or if the patient has high resistance, improve that and whatnot. Now, somebody asked about an esophageal catheter. You can also use an esophageal catheter if you have it available to read that. All righty. There's a question of how would we recognize early trigger for mild work shifting? Well, that's a good question. I would say that early trigger, the key item that you have to recognize is that early trigger will be a mandatory breath. So the pattern is a mandatory breath. So it started triggered by the ventilator, followed by evidence of patient, like you see here. So this was a breath triggered by the machine, and then there is this evidence of activity of the patient. You see the change in flow and you see the changes in pressure. So an important thing for you to recognize, Jay, is that every patient ventilator desynchrony will cause other discordances. So it's expected, for example, if you look at a late trigger will cause abnormalities on the pressure and will cause some degree of work shifting. The one that we call is the first one, the one that is causing all the problems. And in this case, the mild work shifting that you see is the cause is the early trigger. The thing that you need to solve is the early trigger, not the work shifting. All righty. Then you have this waveform, and this waveform is a series of breaths, rapid in rapid succession. You have the pressure, you have the flow and volume. And as you look at it, they are fairly consistent. This is again volume control. So every breath is controlled, and there's again an inspiratory pause, this period over here, in which there is no flow. All the breaths, the pressure looks about the same. So and the decays, every single one of them looks very similar, so, which tells me that I don't see any evidence of patient muscle activity. So immediately that takes this patient breathing fast out of the equation, although it's possible, but I don't see anything that is triggering here or that looks like an abnormality either in the flow or the airway pressure. If I look at the cardiac oscillations as an option, I don't see any oscillations. Actually, all the flow looks beautiful as well as the pressure. So rapidly false trigger is out. The next one is false trigger from fluid in the circuit. I showed you an example of condensation on the circuit, and this is as smooth as it gets. So this is out. But your eyes go down and you see the most beautiful square root sign, in which this is the amount of tidal volume that got inhaled from here to here. And this is the amount that got exhaled. and then the ventilator resets, and again it starts the cycle. So you can see that the flow actually, after the patient exhales, it crosses above baseline, which triggers again the breath, making the ventilator think that this is the patient triggering, and it's just all because of an air leak. This is the same case over here. So this is another false trigger, and this one, although I didn't put the volume waveform, is again another false trigger. This is in pressure control, but it's a false trigger from a large leak. So you can see the flow never reaches baseline. It's really high, as high as it gets. It's flow limited, and so this is a false trigger. All right. From another ventilator, what you have here is pressure, flow, and volume. And what you see here is this pattern, and the pattern is multiple trigger or double trigger. Okay, and so the question is, what is causing this? And this is important for us to recognize that double trigger is not a problem in itself, it's a manifestation of something else. And so we put here several. One of them is auto trigger. So auto trigger can cause multiple triggers. It can be early cycle, meaning that the breath, the inspiratory time set by us is shorter than what the patient wants. Late cycle doesn't cause multiple trigger. Actually, it causes a completely different item. It doesn't cause double breaths. And finally, you see early or reverse trigger. So early trigger meaning that the patient triggered, the machine triggered first and then the patient. So let's take a look at this. And the pattern that you see is the first breath is triggered by the patient. And actually you have a good evidence of patient trigger. You see that drop in pressure, that it's in the pressure waveform. And this is a pressure trigger. So, and we know that because they let the change, there's a changing color on the pressure waveform on this ventilator that signals that. So this is definitely a patient breath triggered. And we also see evidence of pmos. I mean, this is, instead of decaying like this, the patient is actively breathing in. This is exhalation, very active. And then it shifts to inspiration. And this is a pressure control breath. And you can see that it's controlled throughout the breath. And then the breath ends and again triggers again, and the pressure is going below baseline. You see that, how it drops below baseline. So this tells you this is highly suspicious for the patient is doing effort. And actually, if you look down here, the patient was doing so much inspiratory effort, the breath stopped, and the patient immediately got more breath. And then the breath of the patient ends here. And then you can see here a late cycle. So essentially, this is a classic example, Jay, of seeing the cause of this is a early cycle, but it's causing on the second breath a late cycle, and you're not going to solve the late cycle. What you need to solve is the early cycle. So you can have several abnormalities on the same breath. And here's another one in which you see the breath triggers. The patient is doing a lot of effort, then the effort ends, and then there's this, what it looks like as late cycle. And so a lot of inspiratory and expiratory effort. This is a good example, very good example of a double or multiple trigger due to early cycle. And here's a good, actually, let me show you, because this, you will like this. That's why I like this waveform. Is you see the effort of the patient, and then you see how there's this little drop here, like that. I'll show it. It's much better seen here. You see, this is an early cycle. So this is the amount of effort of the patient. Patient is inhaling, and then it ends. And instead of having that nice peak and decay, you have all this area here that is missing, that tells you that the patient is doing an inspiratory effort. So that means that there was an early cycle. All right, we're almost done. This one is an example. And what you have here, this is a different ventilator. You have airway. You have Pablo, early cycle is not the same as double triggering. Early cycle is a cause of double triggering. There's many causes for double triggering. Thank you for highlighting that. Auto trigger can cause double trigger. Early cycle can cause double triggering. Early trigger can cause double triggering. So that's a pattern with many causes. All right, on this one, you have airway on the top. Then this ventilator has the esophageal pressure. So they placed an esophageal balloon. All right. And then on the bottom, you have this waveform plus this waveform gives you the transpulmonary pressure. But we're not going to focus on the last one. I want you to see this. This will help you. If you look at the esophageal waveform, that's the actual truth. That's the patient signal. So you can see on the top, and the first example that you have, you see where this yellow dotted line is. It's at the same time as the one below. You can see that the breath was started by the ventilator, and then afterwards, the patient started the effort. So the pattern is machine followed by patient. So machine followed by patient is what we call an early or reverse trigger. Early or reverse trigger. So meaning that the machine started earlier than the patient. This is a good time for me just to say that why didn't we call it reverse trigger is because reverse trigger seems to have a specific physiopathologic mechanism. And so there's other causes that can cause an early trigger, meaning that image in which you have the machine triggering and then evidence of PMOS afterwards. So not to confuse with mechanistic definitions, we use the term early trigger. However, in the literature, you're going to see a lot written right now about reverse trigger, which is this pattern. All right, the last one for all of you, and we have seen an example of this already. Here, the question is actually how you deal with this. So you have pressure, flow, and volume. You see that this is a pressure-controlled breath. The pressure is controlled during inspiration. It's pressure triggered. You see the flow, because whenever I'm controlling pressure, I see the flow. And I see actually this pattern at the end in which there is this amputation of the peak of the expiratory flow, and the flow otherwise looks passive afterwards. So the question is, I reduce the trigger sensitivity to make it easier to trigger? Do I reduce the tidal volume? Do I increase the inspiratory time? Or do I increase the PEEP? The answer to this one is the most evident abnormality here is the early cycle, and these circumstances you would increase the inspiratory time. And so with that, I think that we end. I have put here, I think it's time for us to answer questions. I'll open up the chat and so that we can see questions coming in. I think Jie is on the line as well as Andrew, and we can answer your questions. I will just give a shameful self manifestation for our team, the SEBA team, and this is free and open to all. You can use this to join us on VentRounds every other Tuesday from 2 to 2:30. It's now only half an hour. And it's free for all. And now we offer CRCEs for all the RTs because we want to speak and hear you more. And then on the bottom is the article that explains the latest of what we have. And as we said, this is something that is evolving, that we're learning more about it. And we really welcome your comments and your thoughts, because that makes us better and we learn more and more. Okay. Let's take yeah, are you on the line? Yeah. Yes, you are. Yeah, any comments? Yeah, I just unmuted you.
Thank you so much. I like all your presentation. As always, I learned a lot. So, and I think we already answered all the questions during your presentation.
Oh, that's good.
Yeah, and just one person said they have some of the figures on ventilator dysynchrony but they don't know how to send to us. Do you think it's a good idea to send to us through email? Then probably we can answer in the future ventilator rounds.
As you wish, Jie, I follow your lead on this.
Okay, so I will leave my email on the chat box, and then everybody can, if you have any difficult question, I mean, patient ventilator synchrony waveform, then you can send to me. I can forward to professor, then he may answer on their ventilator round.
Thank you, Jie. I really appreciate all your support and thoughts, and all of you for sticking and listening to us. Thank you.
Yeah, very effective discussion. Thank you very much. Bye, everyone.
Bye bye.